Good morning, everyone. We would like to welcome you to today's Friday Provider Office Hours on Friday, August 20th. My name is Leslie Amani. I will help moderate today's call, and we're so glad you are joining us today. We'll move on to our next slide. And as a reminder, during today's hour, you have an opportunity to ask questions. Located in the lower right-hand corner, if you can see that, there is a Q&A panel where you select Ask All Panelists, enter your text, and click Send. So whether it's your first time or you are a regular attendee, we invite you to ask questions. Next slide. Housekeeping to our panelists. Please mute yourself today when you are not speaking and monitor the Q&A panel for any questions that you might be able to answer. It's very helpful throughout the hour to get those questions viewed and possibly answered. And a reminder to participants, if you look into the chat, you can access today's slides and archive presentations at eziz.org/COVID/education. Next slide. So today's agenda, we have beginning today after our announcement, vaccine administration from Dr. Louise McNitt, a clinical update following, storage and handling with Kate McHugh, a first section of Q&A. We'll then follow up with enrollment in CalVax grant with Claudia Aguiluz, and vaccine management updates and Q&A with Maria Volk and Claudia Aguiluz. We'll wrap it up and we will move on to our next slide. So we do have some reminders. CalVax grant enrollment was extended to September 10th. If you have questions about the application or you want more information on the grant process, please register for any of the Physicians for a Healthy California upcoming 1-hour webinars. There's one this Monday at 9 a.m. and Wednesday, September 3rd at 1 p.m. The links to register are on the slide. Next slide. And stay informed by looking at eziz.org/COVID, where you have frequent content updates. If you notice on the slide for alerts, there's information on additional doses for immunocompromised persons. We also have information about how to have crucial conversations about COVID-19 with patients that you serve. So lots of great updates and information. Next slide. And if you're looking for some webinars and trainings, this upcoming week of August 23rd, MyCAVax, My Turn on Demand, and Combined Office Hour events are available. Live links are on this slide. And again, these slides are located already on eziz.org/COVID/education, and you can download that slide deck and you can click on those links to get signed up. Next slide. And COVID-19 Vaccine Provider FAQs in its 33rd iteration, updated yesterday to include information about immunocompromised people receiving additional doses, along with what's the difference between an additional dose and a booster dose. So lots of updates and a great resource to use and to share with those who might benefit from its use. Next slide. So moving on to our next slide, we do want to highlight very important announcement. Fraud. If you are hearing of false immunizations and false immunization cards, wow, we want you to make sure that you know where to turn. Providers, if you are hearing of this, please alert your local health department, and you can also report it to the Federal Health and Human Services Office of the Inspector General tip line. The phone number is listed, along with an email web address. You can find more information, but please make sure you're reporting if you're hearing anything such as this. Next slide. And QR code readers came up for digital vaccine records. If you're asked about the QR code readers, and if you note in that upper right-hand corner, that's your QR code symbol. It's verified through Smart Health Card Verifier app. That is the recommended and preferred application. So please make a note of that. And all legitimate readers should follow the Smart Health Card framework. So we want to apprise you of that as a resource. Next slide. And we're going to move right into vaccine administration with Dr. Louise McNitt. Louise?
Good morning, everyone. Next slide, please. just wanted to, sorry, I need to get myself centered here. I have a crabby teenager who's giving me the hairy eyeball right now. So I'm a little distracted. Anyway, the first thing, I just want to remind you of where to find the health officer orders. There's been a couple of new ones, I think, since last time that we spoke. If you want to see all of them, you can just use the link that's at the very bottom of the slide. I think we've discussed previously the first two already about healthcare workers and requirements for visitors to acute care hospitals. There's been a new one about vaccine verification for workers in schools. So teachers either need to show proof of full vaccination or be tested at least once per week. And then one came out just a few days ago about hospital and healthcare system surge. This requires that hospitals notify the MOHOC, the Medical Health Operational Area Coordinator, the health officer, and licensing certification about the ICU capacity and surge capacity of their hospitals, and that hospitals must accept patient transfers regardless of a patient's insurance status or ability to pay. So please, this is a little bit outside of my bailiwick, so please click on the link if you are work in a hospital to find out more details. And then go on to the next slide, please. So just wanted to remind everyone about vaccine equity, which is a really important goal of our COVID-19 vaccine program. We are seeing, we continue to see progress in terms of getting everyone vaccinated, but there's still quite a discrepancy between people who are live in the Healthy Places Index 1 quartile, which is communities that experience the least healthy conditions, between that quartile and quartile 4 in the Healthy Places Index, where people experience the healthiest conditions. So you can see in the dark blue on the left is quartile 1, and in the dark green on the right is quartile 4. So 55% fully vaccinated versus 78% fully vaccinated. And in the graph on the right, it's just showing the same information, but in a line graph. And you can kind of see how things have gone since January. We initially had a very nice rise in vaccination through March and April, and it's kind of plateaued a little bit in June. We're seeing a little bit of an increase over the last few weeks, but we still have a lot of work to do in terms of getting everyone in California protected. Next slide, please. So doses administered to date, we have 45,681,458 doses administered. That's 75% of the 12+ population has received at least one dose, and 65% are fully protected. So that's really wonderful, and keep up the good work. And so we have over 22 million people who are fully vaccinated. We still have a lot of vaccine out there, though. If you see on the very bottom of the slide here, we have almost 5.5 million doses on hand. That's 68 days worth of inventory. So a lot of vaccine available for people to use. Next slide, please. So on to my clinical update. So I just wanted to review some of the information that was shared at the Advisory Committee for Immunization Practices meeting that happened last Friday. This was my favorite slide from the meeting. I think it very nicely illustrates why we want people to get vaccinated and why it's really important that as many people as possible get vaccinated in a community. So this is using real data, but CDC applied this to two hypothetical states, so state A and state B. They both have a population of 1 million people, but in State A, 70% of people are vaccinated, and in State B, only 30% of people are vaccinated. So you can see that in State A, there would still be some COVID-19 cases, a total of about 130 cases per week, 101 in the unvaccinated and 29 in the vaccinated. And that's represented there by the dots. So the little blue dots are the vaccinated cases and the red dots are the unvaccinated cases. So contrast that to State B that only has 30% of the population vaccinated, and you can see that they have over 5,000 total cases per week, 250 in the vaccinated and 4,864 in the unvaccinated. So there's a lot more blue and a lot more red dots in State B that has only 30% vaccinated. So luckily here in California, we're more like State A, but obviously the more people we can get vaccinated, the less transmission there will be, the fewer cases, and the less likely that we'll see more variants like Delta that potentially could have more transmissibility or cause more morbidity or mortality. So next slide, please. So the main point of the ACIP meeting was to discuss an extra dose of vaccine in immunocompromised patients. So since last Friday, there was an announcement by the White House about booster doses for people who have been vaccinated 8 months ago. I am not going to talk about that because there is really not very much information about that other than the CDC will be looking at the data and making recommendations for who should get booster doses. It might be only part of the population. It might be a staggered approach, so people at highest risk first, like maybe people in long-term care first, and then going from there. So still a lot of details to work out for that, so I will stop talking about that and talk about just extra doses for immunocompromised patients. And the difference here between a booster and an extra dose is that for immune-compromised patients, they are less likely to have developed adequate immunity from the 2-dose series. So giving them a third dose is a way to potentially increase the effectiveness of the vaccine. So just why are we looking at immunocompromised patients in particular? They are more likely to get severely ill from COVID-19. They have a higher risk of prolonged SARS-CoV-2 infection, prolonged shedding, and more likely to develop mutations as they viral replication happens for a longer period. They have lower antibody and neutralization titers to SARS-CoV-2. They're more likely to transmit SARS-CoV-2 to household contacts. They're more likely to have breakthrough infection. One U.S. study showed 40 to 44% of hospitalized breakthrough cases were in immunocompromised people. And there's lower vaccine effectiveness for the immunocompromised, 59 to 72% VE versus 90 to 94% vaccine effectiveness among non-immunocompromised people. There's a link to the slides there at the bottom of the page if you want to look in more detail. Next slide, please. So the kind of summary of the potential risks.
Louise, we lost sound. Can you hear me and maybe come back in again? We're going to try to get her back on the line. Seems like we're having technical difficulties on that. I think what we'll go ahead and do, if we can move on to the storage and handling and through these slides. So we'll come back to slide 19 and move on, and Kate or Al, I believe Kate will be presenting today. Kate, if you wouldn't mind taking over and presenting your section right now, we'll wait for Louise.
Thank you, Leslie. Good morning, everyone. Next slide, please. I wanted to give everyone an overview of beyond use dates and expiration dates. The beyond use date is also sometimes called the use by date, and it's determined by storage and preparation conditions, so it varies depending on the vaccine. For example, Pfizer that has been moved into the refrigerator has a beyond use date of 31 days from the date it was moved to the refrigerator. And then after 31 days, you must dispose of the vaccine. For Moderna, it's 30 days after moving it into the refrigerator, and then Pfizer also has that 2 weeks at normal frozen, so -25 to -15 degrees Celsius in the normal freezer. So all of the different vaccines have different beyond use dates, and it's important you pay attention to those. You can find more information in the EUA for the vaccines or on EZIZ or on the CDC websites, but it is really important that providers pay attention to these because it can affect the stability of the vaccine and it can affect how effective the vaccine is in the patient. And then the expiration date is the date by which the vaccine must absolutely be used, and this is determined at the time of manufacture. So for an example, if your Pfizer vaccine expires on June 16th and you moved your Pfizer to the refrigerator on June 13th, you still have to use or dispose of the vaccine by 6/15. So there's absolutely no way you should go beyond the manufacturer's expiration. And it's important that providers pay attention to both the beyond use date and expiration dates. And sometimes the expiration date can change. For example, the Johnson & Johnson expiration date has been extended a few times, and we're hoping we're going to get an expiration date shelf life extension for the Pfizer vaccine in the next couple weeks. And it is important to know that you should report it to VAERS if you do administer vaccine past its beyond use or expiration date, because that is considered an administration error, and you also should contact the manufacturer for guidance to see if they can help you determine if the vaccine was still effective at the time you administered it. Next slide, please. And for expired vaccine, it is crucial to check the expiration and beyond use dates of your vaccine prior to removing from the storage unit, and again prior to administration, just to make sure you're not going to inadvertently administer expired vaccine to anyone. You can look up expiration dates here at a few different links for the different manufacturers. For Moderna and Johnson & Johnson, you can look them up on a website. And then for Pfizer, the expiration date is physically printed on the vials. And we are expecting that shelf life extension, so we'll let you know what Pfizer and CDC recommend for labeling your vaccine if they do receive a shelf life extension. It's important to inventory your vaccine weekly and remove any expired vaccine. And CDC does have some beyond use date labels that you can use for your Pfizer and Moderna vaccine, and it's really important that you're making sure to label those so that you know when the beyond use date is and that your staff know when they can or cannot continue administering that vaccine. Next slide, please. And it's also public safety power shutoff season, so that's when the electric companies shut off power for different parts of the state in an attempt to minimize risk of wildfires and electrical damage to trees that would cause a fire. So it's a good idea for your facility to have a vaccine management plan. This plan incorporates different items, both for your routine day-to-day tasks as well as for emergencies like public safety power shutoffs. And for preparing for public safety power shutoffs, it's a good idea to consider partnering with other providers who may be able to house your vaccine if your facility loses power. That's always a good idea anyway, just in case your facility experiences, like a single building power loss. And for public safety power shutoffs, just because they do cover a larger geographic area, you might want to consider partnering with other providers who are a little bit further away from your facility. It's also important to have your vaccine transport containers and data loggers ready to go in case you do need to transport your vaccine to another facility. and make sure that your staff know how to pack the vaccine and that you already have the materials cooled and conditioned and ready to pack. And I put some links here where you can pay attention to alerts for your area so that you can know if your facility is going to experience one of these shutoffs. They do usually notify you with a few days notice. So depending on what power companies in your area, you can sign up for alerts. If you do experience a temperature excursion due to the PSPS or any other issue, it's important to report those to MyCAVax. And if you have any questions, you can always contact the COVID call center if you need any help, or if you're experiencing a PSPS and need some sort of assistance, you can always feel free to reach out to them. And that is the end of my slides. Thank you, Leslie.
Thank you, Kate. And we're going to move back to slide 19. And as a reminder to attendees, we do have opportunities for Q&A, so please use that panel. And we did put the updated EZIZ link to these slides in the chat. Our apologies, there was a little misstep with that, but the new link is in the chat. And we're going to resume with Dr. Louise McNitt beginning on slide 19. Louise?
Hi, I'm so sorry about that. My internet in my house went out and I didn't realize it. So just back to the extra dose for immunocompromised patients. So potential benefits, emerging data suggests that an additional mRNA COVID-19 vaccine in immunocompromised people can enhance the antibody response and increase the proportion of people who respond to the COVID-19 vaccine. We do not have any efficacy or effectiveness studies, though, following a third dose. Potential harms, there's no evidence that getting an extra dose increases the risk of an adverse reactions, and reactogenicity of the third dose was similar to prior doses. And there are rare but serious adverse events associated with mRNA vaccination, including anaphylaxis as well as myocarditis and pericarditis, but it's not known how having an immunocompromising condition might impact these rare events. And there are no safety studies in additional mRNA doses in immunocompromised adolescents. Next slide, please. So clinical considerations for providing an additional dose. The additional dose should be given, the extra dose should be considered for people with moderate to severe immune-compromising conditions due to a medical condition or receipt of an immunosuppressive medication or treatment. You should consider giving an additional dose in the same age groups as who are authorized to receive the primary vaccination series. So for Pfizer, it's people aged 12 and older, and for Moderna, it's people aged 18 years and older. And there is a link to the clinical considerations webpage there at the bottom of the slide. Next slide, please. So the conditions and treatments that are considered sufficiently immunocompromising to warrant a third dose include, but are not limited to, active treatment for solid tumor and hematologic malignancies, receipt of a solid organ transplant and taking immunosuppressive therapy, receipt of CAR T-cell or hematopoietic stem cell transplant, moderate or severe primary immunodeficiency, for example, DeJoy syndrome and Wiskott-Aldrich syndrome, advanced or untreated HIV infection. And next slide. And active treatment with high-dose corticosteroids, greater than 20 milligrams of prednisone or equivalent per day, taking alkylating agents, antimetabolites, transplant-related immunosuppressive drugs, cancer chemotherapeutic agents classified as severely immunosuppressive, tumor necrosis factor blockers, and other biologic agents that are immunosuppressive or immune modulatory. A patient's clinical team is best positioned to determine the degree of immune compromise and appropriate timing of vaccination. That's a direct quote from the clinical considerations page. And there is more information about immunocompromising conditions and vaccination that is linked in that page, so please review it. And yes, so next slide, please. So additional consideration, the additional mRNA COVID-19 vaccine dose should be the same product as the initial 2-dose primary vaccine series. If the same product is not available, the other mRNA product may be administered. You do not need to report this into VAERS as an administration error like you would have to if there's a mixed series in the primary series. A person should not receive more than 3 mRNA COVID-19 vaccine doses, and serologic testing or cellular immune testing prior to receiving a 3rd dose is not recommended. Next slide, please. The additional dose should be administered at least 20 days after completion of the initial 2-dose series. In terms of timing of the additional dose, providers should take into consideration current or planned immunosuppressive therapy to optimize both the patient's medical condition and response to the vaccine. When possible, all doses should be administered at least 2 weeks before initiation or resumption of immunosuppressive treatment. And for public health purposes, immunocompromised people who have completed a primary vaccine series, so 2 doses of mRNA vaccine or 1 dose of the Johnson & Johnson vaccine, are considered fully vaccinated greater than or equal to 2 weeks after completion of the series. So we wouldn't treat immunocompromised people differently in terms of vaccination completion requirements, if they need it for their jobs or for other situations to show proof of vaccination. So next slide, please. And immunocompromised people, even if they receive a 3rd dose, should continue prevention measures. Immunocompromised patients should be advised that they may have a reduced immune response to COVID-19 vaccine even after an additional dose, and that they should continue to follow current prevention measures, including wearing a mask, maintaining 6-foot distance, and avoiding crowds and poorly ventilated indoor spaces. And close contacts of immunocompromised patients should also be strongly encouraged to be vaccinated against COVID-19 to protect their loved ones or family members. Next slide, please. So CDC has currently has not given any guidelines regarding immunocompromised patients who have received the Johnson & Johnson vaccine. There's currently insufficient data to support the use of an additional mRNA COVID-19 vaccine after a single dose of Johnson & Johnson vaccine. But they are continuing to look at the data and consider options for these patients. After the ACIP meeting last Friday, the Western States Scientific Safety Review Work Group reviewed the ACIP recommendations and put out their own statement. They felt that the CDC's lack of guidelines for people with Johnson & Johnson kind of left them out in the cold a little bit and left providers without any guidance. So in their statement, which is linked there, they recommend that immunocompromised individuals who have received the Johnson COVID-19 vaccine should consult with their healthcare providers, and clinicians should weigh the risks and benefits of a dose of an mRNA vaccine for each such patient, and also to consider the potential organizational and professional risk of the unauthorized administration of a supplementary dose of an mRNA vaccine. So under the current provider agreement, the EUA only allows for additional doses in patients who have received mRNA vaccines and not the Johnson & Johnson vaccine. And the patient should be informed that any recommendation to receive an extra vaccine would exceed current FDA and CDC guidance and is based on the clinician's individualized medical judgment. So if you would like to read that statement more completely, please see the link there in the middle of the slide. Next slide, please. V-Safe has been updated to accommodate a third dose. The app will not send you an automated text because it doesn't know if you've received a third dose, but immunocompromised persons can initiate a health screening and submit their information to V-Safe. And we encourage patients to use the system because it does help CDC collect very important data about adverse events after vaccination. So next slide, please. In addition to the discussion about the extra doses in immunocompromised patients, there was also a brief discussion about COVID-19 vaccination and pregnancy. And also, there have been a couple of other organizations that have released statements about vaccination and pregnancy over the last couple of weeks. So there is a way to look and see how many pregnant people in the U.S. have been vaccinated. There's a link to the CDC COVID data tracker there at the top, the first bullet, and that is data on pregnant people, and there's only approximately 20% of pregnant people in the U.S. who have received at least one dose of COVID-19 vaccine. So in response to this, at the end of July, ACOG, the American College of Obstetrics and Gynecologists, in coordination with the Society for Maternal and Fetal Medicine, put out a statement with strong recommendation in support of vaccination during pregnancy. COVID-19 vaccine is the best method to reduce maternal and fetal complications of COVID-19 infection among pregnant people, according to the president of the Society for Maternal and Fetal Medicine. The Western States Scientific Review Work Group also commented on vaccination in pregnancy and reiterated a strong recommendation and noted that there is no evidence that any vaccines, including COVID-19 vaccines, adversely affect fertility, and that many women have become pregnant after receiving the COVID-19 vaccine. Next slide, please. And the CDC statement came out on August 11th, stating that new data from the V-Safe pregnancy registry did not find an increased risk of miscarriage among nearly 2,500 pregnant women who received an mRNA vaccine before 20 weeks of pregnancy. And the CDC director, Dr. Walensky, states, CDC encourages all pregnant people or people who are thinking about becoming pregnant and those breastfeeding to get vaccinated to protect themselves from COVID-19. The vaccines are safe and effective, and it has never been more urgent to increase vaccinations as we face the highly transmissible Delta variant and see severe outcomes from COVID-19 among unvaccinated pregnant people. And I think that is my last slide.
Thank you, Louise. Yes, and we're going to move right on through the slides to enrollment and CalVax grant update. Maria Bolt has been doing a great job, along with other subject matter experts, answering your questions. And we want to make sure we hear all the important updates. So continue to ask your questions, but right now we're going to turn it over to Claudia.
Good morning, Leslie, and good morning, everyone. Thank you for the opportunity to sit in for Nisha and provide a little bit of the status of onboarding VMC providers into the COVID program, as well as status on our CalVax grant. So let's go to the first slide. Here we go. So we want to keep you abreast of how the enrollment process is going, particularly of enrolling VMC providers into the COVID program. They are a critical group that is servicing pediatric populations, oftentimes serving pediatric populations in underserved communities. And we have quite a bit of providers throughout the state. 3441 is the number of providers that are enrolled in the VFC program. You can see that in the center chart. The good news is that as we're monitoring onboarding of VFC providers, we can see that the number of providers that are joining the COVID vaccination program to also immunize their patients against COVID, it's growing. That is the good news. The other piece of good news is that out of the locations who are enrolling and vaccinating, they are administering quite a bit of vaccines to the populations. You can see about 2.2 million doses were administered last month, and about 46% of those doses were administered in the vaccine equity metric, the first quartile. And that is important because those are the lowest quartile of the Healthy Place Index, which oftentimes provides a score and a predictor of the community conditions and things that would be important to make sure that our patients are protected. 29% are in quartile 2, so I think there is great progress there. We know that there are a number of providers that recently enroll and yet have not been vaccinating, so we're hoping that that number grows. But yet we still have about 67%, close to 68% of pediatric providers that are yet to be onboarded into the program. There are a number of efforts we are doing, and we are asking you as enrolled providers that if you have colleagues that are serving pediatric populations, particularly VFC providers, and have not joined the program, have an opportunity to have a conversation about the important aspect of joining these immunization efforts. We'd love for you to join us at the state, join the American Academy of Pediatrics, the American Academy of Family Physicians, our statewide coalition, in a call to action to hopefully get more providers onboarded. We recognize that there still vaccines are not licensed for kiddos 12 and under, but there is a number of adolescents that are now showing up for back-to-school catch-up immunizations, and we know we're about to enter influenza season. So it would be a wonderful opportunity for co-administration, and we will continue to outreach to our providers in ensuring that we can support them as best as we can. If you know barriers that, maybe they have shared with you or from others, always please share them. Maybe add them to the chat. I think we are doing everything we can to try and support our providers in joining the program. So that is the good news. We have, once again, locations that are coming on board, and we're also tracking the status of their applications. Once again, not only onboarding, not only if they're vaccinating, but also their application process so that we can try and push applications through and help providers come on board. Let's go to the next slide. This is kind of related. We have the CalEx grant, as you may have heard us talk every Friday. The good news is that the deadline has been extended through September 10th. So if any of you on this call yet have not taken advantage of this grant, which provides up to $55,000 to support immunization efforts in practices, please do take advantage of that. That is a wonderful financial support for providers that are helping immunize. Also, good news is that the eligibility for the grant was also expanded, and schools and school-based health centers are now eligible to apply. There is a resource in there for you to see the full list if you're interested. You can just use the hyperlink in this slide. And we'll continue to have webinars to support providers that are on board, that are completing the application, any questions that they may have. So there are 2 sessions that are upcoming, one coming up this Monday at 9 a.m. and then Friday, September 3rd at 1 p.m. As you can see in the latest stats, we have about 14 million funds that have been requested out of this grant, but yet we still have 23 million funds available and remaining. The grant has received approximately a little bit over 1,000 applicants, and 921 have been approved. So once again, please make sure that this message gets to key people within your organization if you have not yet taken advantage of this important grant. Leslie, back to you.
Thank you so much, Claudia. And great information. We'll move on to our next slide. Do take advantage of those trainings. And also, we're going to have in the chat a great opportunity for you to order through a link Rachel Jacobs is going to put in. It's a conversation that you providers can have with your patients by using these wonderful FAQs, English and Spanish version cards for providers to use in talking with their patients about vaccine hesitation and how to build vaccine confidence. So continue to watch in the chat for important links, and we are continuing to view and monitor your questions. We want to go ahead and move on to vaccine management with Maria Volk and Claudia Aguiluz.
Great, thank you, Leslie. Let's go to the next slide. Okay, so this morning we'll talk a little bit about what is now available on MyTurn, a focus on the additional dose capabilities, and then we will talk about what's now available on MyCAVax, talk about some key updates, and focus on vaccine ordering and the fulfillment process with the third-party redistributor. And then, as always, we've got a couple additional slides in the appendix with additional details. Okay, great. So on MyTurn, the release for this week, a few improvements. On MyTurn Clinic, we have embedded some different job aids throughout the portal that direct clinic staff to related training materials, and we think this will be really helpful to have those job aids just at the tip of your fingers when you're going through something if you need a little help versus having to kind of go searching for them. So we hope that our clinic managers really like that new feature. And then just a couple general enhancements, making the pre-registration clinic a specific link. And then again, just along the lines of job aids and knowledge center, working to just improve the accessibility to different job aids and materials throughout the system. On MyTurn Public, we're happy to have launched the group scheduling version 2. If you recall, we initially put the first version in July, but this new enhancement has a lot of improvements that we think people will really like, and this will enable you to create appointments for everyone in the group to ensure accurate capacity tracking. And then a couple other general enhancements. We've added the clinic start and end date to the clinic display on the public site and increased override limits on the active availability portion. And then finally, Google address validation for patient home address, which is something people have been wanting for a while. So glad to have that in the system now. Next slide. But we know what you're really most interested in is the additional dose overview. So as Louise just covered, it was just last week that the FDA announced the recommendation for certain immunocompromised individuals to receive the additional vaccine dose. So obviously this has required a number of changes to MyTurn Public and Clinic, and I'll walk you through those changes in these next couple of slides. And before I do that, I just want to point out that our approach is to implement and deploy kind of our initial set of requirements, so the minimal viable product that we released late Wednesday night, so was in effect Thursday morning, and then continue to add some additional enhancements in coming releases. Next slide. All right, so what went into effect this week is we've added a new landing page section that provides information on additional doses to the public. There are new questions to screen for patient eligibility for additional doses, and we've done updates to the logic to allow for scheduling the additional dose. In an upcoming release, we will be adding a clinic tag so that you can advertise and identify clinics that specifically offer the additional doses, and then we will do updates to our Q&A and our virtual assistant. Next slide. So here's just a screenshot of what it looks like. We will ask them if they've received their first dose, what vaccine, and then ask them which appointment they want to schedule. Is it a second dose or is it an additional dose? If they pick additional dose, they will then be directed to certify that the patient is immunocompromised and then also confirm that they received their second dose at least 28 days ago. Next slide. So for My Turn Clinic, what we've done is we have updated the walk-in flow to add the additional dose as an option, updated the clinic so that they can select the booster additional dose to be added for new or existing clinics. We've added an additional dose indicator on the appointment record and then a report about the additional dose. So post MVP, so in the upcoming release, we will make some changes to the bulk functions, so editing and bulk updating the appointments and the bulk upload of additional doses, as well as adding the additional dose indicator on the appointments tab, and then more work on the dashboard component. So you'll notice in the MVP, we'll have a report for the additional dose, but we will do the rest of the changes to the dashboard in the upcoming release. And then we'll do appointment updates and reminder SMS and emails. Next slide. Okay, great. So here is a screenshot of My Turn Clinic and the walk-in flow. So they'll select, is this your first dose, second dose, or a booster? So this is where I wanted just to make a little point here. As we all know, currently the recommendation is for an additional dose for immunocompromised. Also remember, we just got this last Thursday, and as we were kind of prepping to do it, we were starting to pre-do some work and had started using the terminology of booster, and I think sort of late Friday when we got the CDC recommendations, it became clear that we really needed to differentiate between additional doses and boosters. Due to the really short time that we had, we chose to focus on making sure that the additional dose language was really clear on the public side, and did not have the time to make all of the changes on the clinic side. And also, just knowing that we do have boosters coming, I think this will just give us a little time to think about how do we incorporate both an additional dose for immunocompromised and a booster dose on the clinic side. So we understand that might be a touch confusing, but again, we really focused our efforts on making sure that the language is really clear on the public side, and just ask the clinic managers to understand the nuance there, but they should definitely select the booster for the additional dose. And then it'll walk you through the questions, and you can then, they'll go through the regular vaccine administrator flow to administer the dose. Next slide. Yes, I'm going to turn it over to Claudia now.
Thank you, Maria. Okay, on to my new MyCNX release 15, which was deployed last night. Changes are available now for you as providers and also for local health departments. So we have quite a bit of areas that were touched upon this new release, and some of the key areas are vaccine transfers, areas of small orders, including ordering and review processing for local health departments, a little bit on vaccine wastage redistribution and training. I would like to just emphasize the picture on the right over here, I think it's right, that we share with providers prior to the release, prior to every release, and it contains all of the notes of what is changing and kind of why it's relevant for you, why it matters. So if you have not had a chance to open this communication and take a look at what's changing, highly encourage you to please do so, and also share with key relevant staff that need to be aware of what's changing. So let me just cover a few key items from this release, and let's go to the next slide, Leslie. This is kind of a hybrid slide because in the release we included information about product availability and the fact that we are now turning on a particular vaccine product and turning on another product, and that is because CDC notified us this week about changes in product availability. In addition, we also sent another communication to you all outlining all of the key information for the new products that are available and the ones that we're turning off. Specifically, I want to highlight for you this morning the fact that Pfizer, in terms of Pfizer vaccines, the 450 NVCR pack is not available for ordering as part of standard orders. Yes, I know what you're thinking. And this will be until further notice, and this is effective today. Actually, CDC turned off that product well, early this morning, around 6 a.m., so this product is not available for ordering. The good news is that Pfizer 1170 has now been reintroduced. It was quite a shock for us because we didn't think that was going to come back, but it did, and it is now available for ordering starting today, actually. So you will see a change if you go and place an order. If you're placing standard orders, I think most of you place your orders on Monday, and I want to just cover vaccine order cadence really quickly. But I think you will see that change in the vaccine order formulary. So specifically for the Pfizer 1170 NDC that is coming back, I want to highlight a number of key things for you. First and foremost, the ancillary kits will be configured to include all 25 gauge 1-inch needles for vaccine administration. So it's the same kits that you are receiving with the 450 right now. So, you know, that's that. A reminder about the kids, since I'm talking about kids, we cannot opt out of ancillary kits, especially because your Pfizer kit contains your diluent. So just a note that please don't return, don't reject any ancillary kits. I know some of you have enough supplies, but you could potentially redirect them to other vaccine efforts, including influenza, which is right around the corner. So please don't reject ancillary kits. Second is that if you intend to use the 1170 packaging in the thermal shipper, we want to make you aware that this 1170 will not come with dry ice refills. So you will have to make your own planning and coordination to ensure that you are refilling ice every 5 days if you are still storing vaccine in the thermal shipper. And then if you are storing it in the thermal shipper, please make sure that you are following instructions on the control end. Even if you're not, just please make sure that you're turning it off so that you're not getting calls in the middle of the night for alerts. And then the other thing we wanted to mention for you is the extension for Pfizer is still, for Pfizer that has been stored at ultra-low temperatures condition, as I mentioned, it's still forthcoming. So please consider this extension prior to placing your orders, because we hope to hear the week of the 23rd, that's next week. I know it's going to be cutting it close, but we want to make you aware about that. So if you're storing Pfizer in ultra-low temperatures, you know, information is forthcoming for that 3-month additional extension. Okay, so let's go to the next slide. So here's a highlight of a couple of things that are changing in MyCAVAX, and one that is going to be very key for you if you have or had pending transfers is changes in the vaccine inventory management section, the transfer section. We had quite a bit of pending vaccine transfers to be accepted in the system. So there is new functionality added to MyCAVAX. So a pop-up has been added for the receiving location. Well, a pop-up has been added into the system. So any site that has any pending transfers that have yet to be accepted will get this pop-up box that says action required. Please go ahead and either accept or reject your transfers. This pop-up will come up when you have your location coordinator and organization coordinators logging in the system. And yes, it will come up each and every time until you take action. We had quite a bit of transfers that were pending. In order to facilitate the implementation of this change, we went ahead and accepted those transfers for you if you had pending transfers. If you were part of the sites that had pending transfers, you also received a targeted communication just letting you know that we were going to do this. So you should have that in your inbox. And for future either emergency transfers or redistribution transfers, we are reminding providers that are sending the transfers as well as receiving the transfers that these need to be documented in MyCAVAX. and the receipt needs to be done immediately in the system. So please help us make sure that we have accurate information in the system, and most importantly, that we have your inventory recorded in the system. The second change on vaccine transfers is that beyond use date, if it's applicable, is not required. And a new reason has been added to rejections. So as I was talking just a few seconds ago, if for some reason you have a transfer that you cannot accept, you now have a set of reasons to describe why you are not accepting or able to accept that transfer. So that is new. And then just as a reminder, the vaccine accept or reject button is at the top right of the vaccine order page to help you complete that process. Just quickly, waste events. These is important to report. And so we added a COVID ID to waste events to be able to track them and identify them better, but also added a transfer submitted field to the excursion report form for waste events. We also want to make sure that if there is a temperature excursion that occurred during your transfer, that you report that prior to just calling the vaccine a waste. So I think we're making the link between both those forms and just adding a little pop-up to help the users and guide users with the recording of these transactions. And I think that may be my last slide, Leslie. Great, thank you. Just really quickly, I know Maria mentioned we had one topic for you, that the third-party redistributor. We are going to provide more information for you next Friday. So that's just a note that we're not mentioning that right now.
Thank you, Claudia. I do want to stop at this slide for just a moment. If we could go back one slide in the appendix, please. Yes, thank you. Right here. Do remember, next slide, please, that we have a My CAVAX feedback form, and we invite all of you, please submit your feedback to that team. They will look at your direct feedback and assist the team in identifying and prioritizing upcoming needs. So as a reminder, again, in the appendix, the first slide out, there is a feedback form. Click and give your input. All right, let's move on to Q&A. And as a reminder to all, we are monitoring. I'm going to hand it directly over to Maria Volk to see if we can get any question or comment in before we close things up.
Great, thank you. I know we've answered most of the questions. Just a couple of things that have come up a couple times that I want to highlight. A number of questions have come in about the registries. And I do just want to emphasize for all attendees that all of our California registries can currently accept a third dose. So there is no issue with those coming in. A couple of questions just about the digital vaccine record. And yes, that does pull from all three registries. Currently, federal doses from federal entities are not in our registry, so those providers are not getting their records from there currently, but we are working with CDC to get those federal doses into the system. And then just one other note, Claudia talked about the shift from the 1170 to 450, and a couple questions came in. Yes, that is for standard orders. Smaller amounts are available through the small order process if you cannot use the 1170s. I'm thinking that's probably all the ones I can get through, Leslie.
Thank you, Maria. As we move on, we do want to thank you all for attending and thank all of our panelists, Dr. Louise McNitt, Kay McHugh, Claudia Aguiluz, and Maria Volk for preparation and for answering questions. We do also want to highlight that if you know of VFC providers who have not yet onboarded, we really want to highlight opportunities to connect with them. If they are concerned about the enrollment process, we want to make that easy and guide them. So please encourage folks to reach out to the enrollment team. There are the wonderful incentives of the CalVax grant, along with support in place. So we are talking to those who are already providers, but we do want to encourage you to encourage others to become part of the California COVID-19 vaccination program so we can continue in our efforts to get Californians vaccinated. So we'll move on to our next slide. For additional help, this is a great slide to take a screenshot of, and it has information on the California Medical Association for enrollment support. We were just talking about enrollment, and at the bottom row, the CalVax Grant Program support, which is an incentive for current providers as well. Just to remind you, you are eligible if you have not applied yet. Please make note of that. We also have information for MyTurn, MyCAVax, and the COVID-19 Provider Call Center for providers in local health jurisdictions. Next slide. And if you hear it, clear it. Please send any issues of mis and disinformation to rumors@cdph.ca.gov. Next slide. Thank you for joining us. Monday, August 23rd, detailed MyTurn and MyCAVax training and demo, 12 p.m. Please join that call if you're interested in learning more. Providers are welcome. And next Friday, we have provider office hours, Friday, August 27th, beginning at 9 a.m. And we just know you're grappling with a lot between, quite frankly, the ongoing determined fight to get Californians healthy and well, and between the weather issues of heat and smoke for many of you at this time. Our hearts go out to those who are in a position of really struggling and feeling overwhelmed. And we encourage you to take a moment to breathe, and we just want to say thank you. And we are grateful for all of you as you continue with your efforts to vaccinate California. And with that, we conclude today's call.